Good morning. Welcome to my DVT video. It's kind of a remake, so wish me luck. This is deviations in air transport, kind of a continuation from the anemia one. And a deep vein thrombosis is an indication that blood flow is being impeded or it's being stopped. Please make sure you understand the anatomy and physiology of the venous structure and the arterial structure, especially that in the lower extremity. The objectives of this lecture is to interpret the cardiovascular assessment, to derive at potential and actual nursing diagnoses, which we are becoming familiar with now more than ever, analyze pathophysiological changes in the transport of air, list expected outcomes for transport problems, select nursing interventions for patients with air transport problems, and the pharmacological agents that may be used and their actions and nursing responsibilities. Think ahead. You all know about compression stockings now, and you all know about the TED stockings. So it's their use of those stockings. And of course, paying close attention to the NCLEX. Make sure you're looking at the health promotion and maintenance and the physiologic integrity of the human body. You must be familiar with the circulatory system and its responsibilities for the transportation of oxygen and nutrients. You must understand how the heart pumps blood away from the heart and how the heart is responsible for the blood flow against gravity back to the heart again. The oxygenated blood is pumped back through capillaries into the veins, and then it returns to the heart. So you must have very good response from the valves in order to prevent blood from backflowing. I kind of labeled this slide when things aren't working well, and that's when you develop a DVT, a deep vein thrombosis. And don't forget, you have superficial veins as well. The superficial veins are just under the skin. They're low risk when they have clots in them, and they usually dissolve on their own. You might notice some tenderness and some redness at those particular sites. On the deep veins, you have the femoral, the iliac, the inferior superior vena cava, the axillary, and the subclavian. Yeah, you're going up a little bit higher in the body. The deep are a little bit more thin-walled. They occur more in the lower extremities, and they're usually in the left leg, especially in pregnant women. They are associated with edema, which results from inhibited venous blood flow. So please, again, make sure you understand that there is two systems of venous structures. There's a deep vein, and then there's a more superficial vein. The DVT results from the formation of a clot inside of a vein. The clot either partially or completely becomes blocked, and it stops blood flow or it limits blood flow. The deep veins are surrounded by muscles that contract and bring blood back to the heart. When blood is slowed due to illness, injury, or immobility, blood will pool and stasis will occur. And that's a huge problem, and one of the best ways to prevent that from happening is those muscles that surround those deep veins need exercise. It's an essential part of circulation to allow for the contraction of that muscle, and the best way to accomplish that is through exercise. Virchow's triad describes three broad categories of factors that are thought to contribute to thrombosis. That's that hypercoagulability, where you have hemodynamic changes, injury to the blood, the vasculature, and that could predispose somebody to clotting. Venous stasis or blood flow is decreased in situations like heart failure and in shock. So when you think about it, why are people with heart failure more susceptible to clotting? And it is because of the stasis of blood, because the heart is not effective enough. So normal blood flow is dependent upon the actions of the muscles and adequacies of valves. Bed rest can reduce blood flow by up to 50%. It is said that even blood flow when a person is at rest is almost thickened because of an enzyme that's secreted. And the reason why it is secreted is because the body is trying to accommodate for that heavy-duty rest and make it easier on the heart. But by making it easier on the heart, unfortunately, it could cause clotting or stasis of blood. Don't forget, vessel walls can be damaged by fractures, dislocations, potential IV therapy problems, trauma, surgery, chemical irritations, chemotherapies, dialysis, when people have a therapeutic nutrition intravenously. Damage created to any of those areas can cause clot formation. Pregnancy is also a huge hypocoagulability episodes. Anemias that we discussed before, malignancies, cancers, dehydration, and pregnancy are all responsible for the blood getting thicker. So when you are thinking about that thrombus that is forming, there's a collection of platelets, fibrin, white blood cell, red blood cells, and they get stuck to that vein wall. Don't forget, any type of inflammatory process, excess blood sugar, excess sugary diet causes damage to the vascular wall. And unfortunately, that damage includes cracks and splits in the vascular wall. And that can cause the formation of these red blood cells, this debris. And that could promote the development of the thrombus. Well, we have those collections that thrombus occurs. As the thrombus enlarges, it increases the red blood cells at that site, making the clot even larger and causing a possible occlusion. The process takes about 5 to 7 days from that initial injury that may have resulted, and that organization results in the formation of a thrombus. And that thrombus is like a tail-like appendage, and it's formed and it continues to grow, and then it could potentially break away. That's called a pulmonary emboli. A formation of the thrombus often is accompanied by thrombophlebitis, irritation, edema. That's a huge problem to the limb. More common in the lower extremities than in the upper, but don't forget the upper extremities caused by catheters, dialysis can result. So that thrombi is an aggregate, a collection of platelets attached to the venous wall, resulting in that appendage. Most DVTs occur over the age of 60, but it can strike anybody. Immobility, decrease when that muscle is not used as effectively, decreases venous return, it slows circulation, and can cause the formation of a clot. AKA, surgical procedures can do that. Injury, athletic injuries, don't forget those as potential sites, can initiate blood clotting process. Radiation therapy can also do that as well. Clotting disorders are usually inherited. There's usually a history of a DVT. People of European descent, African Americans, are also at high risk for that. Genetic mutations, which include factor V, that Leiden factor, where the prothrombin gene is mutated, and it can cause blood to clump, of all gross things. So risk factors that are associated with DVTs, of course, are infections, which stimulate blood clotting processes and promotes that formation of the DVT. Oral contraceptives, which also stimulate those blood clotting factors as well, particularly when combined with smoking, which makes platelets far more sticky, and unfortunately they stick together far easier. Cancers, some cancers release prothrombic substances, which increase the tendency of the blood to clot. Cancers, including ovarian, liver, colon, and stomach cancers. And pregnancy, unfortunately, is 5 times more likely to cause the development of a DVT in the 3rd trimester, and it's usually in the iliac vein, and you usually will see it promoted on the left side more so than the right side. Risk factors also include smoking, which reduces the amount of circulating oxygen, damages the vessels, and causes clot formation. Obesity and that sedentary lifestyle can cause cardiac disease, poor cardiac output. When you have that potential, you have the potential for more stasis. Air travel or anything that involves prolonged sitting decreases circulation, and especially in anything that's that tight packed seating, which of course during COVID we're not in any way trying to encourage. But all those things which incurs that knee bending that he's doing right in that picture, the worst thing you could do to make the sluggishness of blood occur. Most risk factors you have are more likely, the more risk factors you have, the more likely you are to develop a DVT. Again, a picture of a DVT with that. Again, unfortunately, what this is a picture of the right leg being inflicted with a DVT, but you do see that edema. If you were to do an assessment and just a very, very casual look at this person's leg, be it male or female, hairy, maybe a male, you could see that he has probably Other risk factors, including peripheral vascular disease, because when I look at his lower extremities, I see it, they are darkened. And I don't see anything that's necessarily related to arterial, because he doesn't have any blueness, or there's no cyanosis in the lower extremities. But I do see there's some type of blood flow issues, and I'm looking at those toenails, and I'm almost curious to know if there's any other problems that are associated with this person's, and there's other comorbidities. And I think the answer to that would be yes. But again, you'll see signs and symptoms can be nonspecific, and the problem with it is a lot of times most people don't know that they have a clot until it breaks off and it becomes a PE, which could be a problem. So anyway, you're looking for, as a result, you are looking for signs and symptoms that may be like as potentially obvious as this person's, but also too signs and symptoms of a pulmonary emboli. When signs do appear, the clot interferes with blood flow, and some local inflammation can occur. Some patients present with that PE, which is that first signal, so you want to make sure you're looking for signs and symptoms of maybe mental status change. A Homan sign, pain in the calf when you do a forced dorsiflexion, is also a sign of this clot, but please, it may be unreliable. Don't massage anything. With clinical manifestations include edema, pain and tenderness, redness, and skin which is warm to the touch. Ways of making an assessment include that ever important health assessment and general survey. A physical examination with signs and symptoms of a DVT can mimic other problems. So you want to make sure that it's not muscular pain, that the patient is reporting it as muscular pain because he's exercising. Hey, it could be a DVT. A duplex venous Doppler can necessarily tell how the blood is flowing through that area and if it is impeded. A venography, be careful because that graphy indicates that there is a dye, and that dye could include potential allergies, so you would always ask in that health exam, does that patient have any allergies? An MRI and a D-dimer. And a D-dimer would necessarily show that if there is any type of fibrin degradation in the body, meaning that the only way that D-dimer is going to work if there is other areas of breakdown of a blood clot, it will necessarily show the products of a blood clot floating around in the bloodstream. D-dimer would be positive, and the higher the level, the more likely you are to have a blood clot. Medical management is to prevent further growth. You might be using something that is an anticoagulant therapy that prevents the extension of a clot and can be supported by bed rest, or sometimes you can use something like a thrombolytic agent, which would dissolve that clot, which is usually consistent with a stroke. Streptokinase may be one of those medications that you were referring to, or a different derivation of streptokinase, but those are thrombolytic agents, and you have to be very, very careful with the use of thrombolytic agents, especially if there's any history of bleeding, gastrointestinal bleeding, maybe a old stroke site, which is in the brain. If a person has any evidence of that, you cannot use streptokinase. It will break down any clot that has formed. And then, of course, there's surgical intervention, which includes going in there and putting in, removing the clot by a surgical intervention and placing in a filter. Anticoagulation therapy includes heparin, agatrovan, low molecular weight-based heparins, Coumadin, warfarin, Xarelto, Pradaxa, which are other by-mouth, the Xarelto and the Pradaxa. You've heard those on television. Common side effects include death. Yes, they can cause bleeding. These are PO medications, kind of new onto the market, but they seem to help prevent the extension of a blood clot. They are also serve as blood thinners, which could also help stop the formation of clots. Heparin, of course, is a little bit more of a nastier beast. When it's taken IV in IV forms, it will help prevent the extension of a clot and hopefully allow the clot to self-absorb. Goal. When you are doing heparin, the test of choice is called a PTT, where you're checking the blood clotting times, and you're actually looking at it in seconds, how long it takes blood to clot in seconds. Lovenox is that low molecular based heparin, which is usually used for short-term therapy, usually before a person is going into a surgical procedure. They'll use Lovenox sub-Q. If you all had the opportunity to give Lovenox, it is a sub-Q injection, 1 finger's breadth away from the umbilicus in the abdomen. The reason why you do it there is because it's a great source for the capillary response is great in that area. So you want to use it in that particular spot to get the maximum absorption. Some of the reasons to not use anticoagulant therapy is because a person has a history of bleeding disorders. They have severe trauma. They have severe renal disease or a liver disease, or they had a recent cerebral vascular hemorrhage. You don't want to cause rebleeding. Heparin is one of those anticoagulant therapies. IV infusion of it is usually how it is initiated, and it's a weight-based protocol. And it is quite an elaborate protocol in which you have to have a prior PTT. You have to make sure that you have a established weight, and that information gets sent down to pharmacy. The heparin prevents activation of clotting factors. Heparin can be given sub-Q for DVT prophylaxis. Dennis Quaid has a child, I don't know if that was the incident where the wrong dosing was given and the poor baby received 10,000 units instead of 5,000 units sub-Q. Used prophylactically in the hospital to prevent the formation of blood clotting, very, very commonplace. It does work on the intrinsic common pathway, and it interferes with the clotting cascade. Uh-oh. I don't know if you remember the clotting cascade, but I'm going to ask you to please just take a glance at the clotting cascade. You'll see things like factor 10, factor 10A, and those are areas in which medications are targeted to stop that clotting process. And as you will see, that it becomes, if you utilize medications that cause or interrupt the clotting cascade in different locations, the need to do a PT-INR, a PTT are no longer necessary, but we'll discuss that as those come up. Heparin, there's no by-mouth form of heparin. It's usually subcutaneous or IV because it really doesn't absorb well in the liver because of the liver, which kind of promotes an enzyme to kind of stop it from working. So it has to be given sub-Q or IV. And you have to be careful when you're monitoring a patient for hemorrhage, falls, anything like old surgical site interventions. You've got to make sure that these people are monitored. A nosebleed could be a death sentence because, and people do get spontaneous nosebleeds by nothing less than, of course, oxygen therapy that we give in the hospital. It's weight-based. If a person has renal insufficiency, please make sure you're giving them a lower dose or that the doctor is aware of a renal issue. Monitor blood H&H and make sure that that is running well. The side effects, of course, can be bleeding and rash, and an adverse effect can be thrombocytopenia. And a lot of times you'll see unable to give a heparin IV due to thrombocytopenia, and you'll see that as an allergic reaction or an adverse reaction. It is a medical crisis when a patient is into a thrombocytopenia. When you are giving heparin, please make sure you are monitoring for signs and symptoms of bleeding, watching the gums, soft toothbrush, nosebleed. Make sure you're watching people who are receiving O2 nasal cannula, stools, people who have any evidence of GI bleeding. It will show up very, very quickly in the stool, turning black or looking like there's blood in there. Avoid IM injections at all costs because it will bleed into the periphery. Looks pretty nasty. They have to be monitored with an APTT. And they have to monitor the platelets. An APTT is what is called an activated partial thromboplastin time. For heparin IV, the APTT should be 1.5 times the control. The normal value is 30 to 40 seconds, so you are looking at something that's going to record at 45 to 60 seconds. The antidote to heparin IV is protamine sulfate. Knowing what those antidotes are is very, very essential because you're going to find that heparin IV has protamine sulfate. Coumadin, which is the therapeutic form of heparin, is going to have vitamin C as its antidote. Agatroban is another form of IV therapy for people who have heparin-induced thrombocytopenia. Its onset is completely different, but it's still on a weight-based protocol, and it inhibits thrombin formation. Its metabolism is primarily in the liver, so you have to be careful if there's any liver issues, hepatitis, any potential liver damage that may be part of this patient's history. Side effects include bleeding and hypotension, diarrhea, nausea, and vomiting. There is no antidote for it. That doesn't mean that that's an awful thing. It just means that its half-life is fast enough that it will go through the body kind of quickly. But it may interfere with the INR, and caution in giving patients concomitantly with Coumadin. So if you're giving Coumadin and agatroban, it will mess up that INR, which is so essential for the therapeutic establishment of Coumadin, the Coumadin medication itself. Low molecular weight heparins can be given at home, and you'll see a lot of people will take them, and they usually are given them 5 to 7 days after surgery and maybe 3 days before surgery, but they're always discontinued 24 hours before surgery. They are long-acting, and they're usually considered reliable. All agents are destroyed by enzymes in the GI tract, and so they must be given parenterally, so you'll see those sub-Q injections. They may cause dizziness, headache, constipation, urinary retention. They can cause bleeding. They can cause anemia, so caution in your patients with anemia. Make sure the patient is not receiving aspirin daily, or if they are, make sure there's an order that specifically says, okay to give aspirin while giving low molecular weight heparins. Make sure you're watching for Coumadin and NSAIDs as well. Watch and don't forget to ask a patient about their naturopathic medications, which include anise, chamomile, garlic, and ginger. Nursing implications for low molecular weight heparins, of course, include the same thing. Assess for signs and symptoms of bleeding, monitor platelets for stool and guaiac. And of course, guaiac just means bleeding into the stool. Low molecular weights include low molecular weight heparins include Lovenox, Fragmin, Normaflow, Orgarin. Yeah, I can't pronounce the rest, but most importantly, please make sure that the antagonist that is available for these types of medications is protamine sulfate. So those would be the antagonists that would be given for low molecular weight heparins. Oral anticoagulants is that good old Coumadin that you see people go home with very, very consistently. Coumadin, don't forget, is rat poisoning. I hate to say it. Coumadin was used as a rat poisoning because poor little mousey or a rat would go home after ingesting Coumadin and bleed out. Hey, it works. It worked in mice, so it will work in humans. It is inhibited by vitamin K. Vitamin K involves the synthesis of clotting factors, and if you look at that clotting cascade, you will see where vitamin K kind of falls into that clotting factor. It inhibits the synthesis of vitamin K, thereby affecting clotting factors. People often refer to high nutritional foods that are associated with vitamin K, include green leafy vegetables. As long as the patient is consistent with the amount of green leafy vegetables that they are ingesting, they may maintain the use of salads and other things. If they're going to convert to being a vegetarian, it's going to throw off their PT-INR values when they're doing that therapeutic level. So you have to make sure that their diet is going to remain consistent, because that's what the blood levels are going to be associated with, is with their current blood levels, which is associated with their diet. Coumadin is a long-term therapy after heparin, and it usually impairs the utilization of vitamin K, and it must be stopped prior to any invasive surgery. So you must advise your patient to let your doctor know that they can't have the surgery until they are off the Coumadin for a while. It does cross the placenta, and it is protein bound. Protein bound means that it is able to adhere to other enzymes in the intestinal tract, and as a result, it will be released over time and become more bioavailable. But as it is bound, it will not be able to do that. But over time, it's a slow release. That's why you're trying to get these therapeutic levels. It will eventually break from that protein binding and become bioavailable in the body. Metabolism is in the liver. Side effects of Coumadin include cramps and nausea. Its onset is within 2 days, and it peaks in 1 to 3 days. Its duration is 2.5 to 5 days. When you start seeing orders for Coumadin, it's going to look really weird. Day 1, take 2.5. Day 2, take 5. Day 3, take 2.5. Day 4, take 7.5. They're very specific as far as ordering requirements when it comes to Coumadin orders. So those therapeutic levels have to be continually verified by lab values. So you're going to, when your patient is receiving Coumadin, please assess for signs and symptoms of bleeding. Monitor that PT and INR. Essential. Coumadin, think of PT-INR. Heparin, think of PTT. Those are those monitor tests that you will be looking at when you are surveying a patient for therapeutic arrival at the therapeutic level. ProTime evaluates the extrinsic clotting pathway. Look at the intrinsic and the extrinsic. Results are reported in a time scale of how long it takes the blood to clot. Therapy is usually lasting for about 3 to 6 months, and monitor those PT-INRs daily, weekly, and monthly. The medication dose is regulated by that PT-INR. The PT is 11 to 12.5 seconds, which is normal. You want it to be 1.5 or 2 times greater than that value. So you want to see it for therapeutic levels between 16.5 and 25 seconds. An INR is 0.8 to 1.2 seconds, which is the normal value. But again, you want it to be about 2 to 3 seconds during that treatment. So a lot of times I'm expecting to see my INR to be 2.8 or 4.2 in that range. The length of treatment depends upon the history and the patient's risk factors. Remember I told you about the screwy dosing? Well, that's why the medication comes in many values: 1 milligram, 2 milligram, 2.5. It comes in different total volumes. Monitor a patient for their vitamin K. Make sure they're taking the medication as directed, which is usually in the evening. A lot of times in the hospital, you will do a PT-INR in the morning, and you will have a prescribed dose in the evening. The anticoagulation effects occurs within 2 to 7 days, and again, its antidote is vitamin K. If you miss a dose, take it as soon as you remember, but try to make sure that you're not doubling doses. If it's coming too close to that other dose, you might have to skip it or call the physician, because you shouldn't be missing a dose, but you want to make sure that there's the time between each dose and you're taking it at about the same time. Coumadin interactions: salicylates, good old aspirin, neomycin, antibiotic, quinidine, and NSAIDs. Herbal interactions include garlic, green tea, ginseng, and I'm sure there are many others. You must have a full health history and a medication or naturopathic medications of that patient. Xarelto you've heard on television, and you will again see that when you look at the clotting cascade, you'll see factor 10A. It's an inactivation at that part of the clotting cascade, and many of these medications are engineered to hit different areas of the clotting cascade at different periods of time. So look at that clotting cascade again and look at factor 10A. It's used to reduce the recurrent DVT or the pulmonary emboli prophylactically, and usually used after knee surgery, hip surgery, any major surgery you may see it being used. You don't have to worry about monitoring lab work because we know it works. There is no antidote. Its half-life is 17 hours. It's excreted via the kidneys, which means you must establish a health history that is looking at kidney function. Watch for signs and symptoms of bleeding. The dose may be consistently 2.5 milligrams in tablets twice a day. Pradaxa is one of those medications you've seen advertised on television. It inhibits thrombin formation. It has very, very few drug interactions, so it's kind of a cool drug, and it has a wide therapeutic index, which just means that the dose range or blood plasma level or serum concentrations usually expected to achieve a desired therapeutic effect is great. So really, as a result, you can't really monitor for it because it works at different levels. That's just the nature of this particular drug. That's why you can't monitor it for lab work. But it does have an antidote, Praxbind, And if you forget about the other one, I know it has a MAV ending, forget it. So, but it does have an antidote in particular. Surgical therapy, again, is used to prevent that PE. You don't want anything on that clot to break off and go right into the lung. It also is used when a person can't use anticoagulation therapy. Remember I told you about the thrombocytopenia? If they have a contraindication, they might have to go in and surgically remove that clot. But then you also still have to be careful about the PE, and you also have to worry about preventative. Venous drainage is compromised, and it will be extremely affected. So you want to make sure you are doing this intervention because absolutely you got no other choice. So that surgical intervention is just supposed to show you that, oh, there's the clot. We're able to find it by doing that ultrasound, and we can find where that clot is. We'll go in and we'll actually remove that. And a lot of times you'll find the insertion of a vena cava filter or a Greenfield filter. And it is really that really weird looking filter that you see off to the right side. That filter is often embedded with streptokinase. And as a result, when the clot hits that area, it will kind of dissolve a wee bit, break apart. More like dissolve a little bit, but now the trick is when that clot is there, you're also going to have to do something about removing it or potentially make sure that it just dissolves very slowly and effectively. That patient has to be observed big time. Nursing management of your patient with a DVT. Make sure you're constantly assessing that patient. Please make sure you're monitoring for mental status change as well. Your plan of care is to monitor those lab values, to monitor for complications, for teaching and prevention. The teaching must go on. That's why I keep criticizing you guys. When I don't see teaching on your care plans, I freak out because if you're not teaching your patient, what's the purpose? And also to prevention. Make sure that you are preventing the formation of another blood clot. That's the last thing this patient needs. Make sure you are establishing a health history. Make sure you're doing a general survey. In the health history, obese? Is there prolonged bed rest? Does this patient do exercise? Is there any history of cardiac disease? What are those risk factors that that patient has? What are those medications that patient is ingesting, including the naturopathic medications, contraceptives, aspirin, any surgical history? What is their diet like? Are they the vegetarians? Are they the green leafy eaters only? Where are they in childbearing status? Is that the reason for the clot? Physical exam. Is there pain in the affected extremity? Is there any increased warmth? What's going on with the circumference of that limb? Nursing diagnoses for a DVT include alterations in tissue perfusion. Don't forget also the potential diagnosis of pain caused by that impaired circulation. Again, no oxygen transport to that area, it's going to cause pain. Alterations in skin integrity related to altered tissue perfusion. Hey, you're using the diagnosis to explain a diagnosis, but you can tell that there's a risk in tissue perfusion because there's warmth to that site, there's poor circulation, you're not able to get an ultrasound on that blood flow. Of course, it's always your hope to improve blood flow, to relieve pain, to decrease the edema, to make sure there's no signs of any skin ulcerations, and to prevent complications, and that includes that PE. It's hard to prevent the complication, but the objective is you want to make sure the patient maintains bed rest so the clot doesn't break off before it gets the chance to be reabsorbed. Monitor lab values, maintain bed rest, and elevate that extremity. Provide elastic stockings, well, we'll call them the TED stockings. Maintain comfort, and monitor for complications. Maintaining comfort may include the use of a Tylenol, may include some type of pain relief. Monitor for complications. Look for blood flow interruptions. Look for coldness of extremity. Look for change in mental status. Get ready or check lab values. The APTT, if they're on heparin. In Coumadin, that PT-INR. Those labs have to be, if they're in the hospital, that has to be done daily. In home care, you may be going twice a week to monitor their PT-INRs. Platelet count and their H&H. Those are very necessary lab values don't forget H&H. We're looking at platelet count, and we're looking at the red blood cell carrying. Are they anemic? Those elastic stockings. TEDS. Prophylaxis for potential to avoid clot formation. TEDS stands for something, thromboembolic deterrent. The TEDS are used while you are in bed. They must be measured appropriately. You want to make sure that they are not bunched up, gathered up. You want to make sure that the compression is where the compression is supposed to be. The venous, these stockings, elastic stockings, simulate the idea that your muscles are helping you. It's an external muscle, basically. It's that elastic stocking. Compression stockings are usually worn when that patient becomes ambulatory. Monitor for skin integrity. Another bed rest thing is the sequential compression devices, and you may have gotten the opportunity to see that in the nursing home. You'll see the uses of those stockings to help simulate the idea that the person's walking. Monitor pain and make sure you're giving them analgesics if they need them. Apply heat compresses if ordered. Keep the affected leg elevated. And measure the thigh and calves daily. Hopefully it's decreasing in size and not increasing in size. Complications include bleeding, thrombocytopenia, and drug interactions. Kind of makes sense when you're talking about interfering with clotting times. Drug interactions, I don't want to give aspirin while giving a blood thinner. It is a blood thinner. The picture off to the right, a common occurrence, especially in a patient who is receiving Coumadin. I'm sorry, heparin sub-Q. When you look over to there, you'll see that in an injection site that's almost far over, a little bit too far away from the umbilicus, you'll see that bruising. The only thing that bothers me about that is it almost looks like there is a area of toughened skin, almost like it's almost like forming a hard shell. Sometimes I'm afraid when I see that, because that's very consistent with what an allergic reaction looks like when you are giving heparin and heparin-based products. But that is severe bruising caused from, I don't know, I'm getting kind of worried. Is this patient able to clot effectively? And I'm also worried, is that patient receiving that injection appropriately? But bruising is a common side effect. Not only will you see it on the abdomen, but you might see it on the arms as a patient hits a side rail. Sometimes turning and repositioning a patient when you place your hands on their arms to turn them, sometimes that causes bruising as well. Make sure you're monitoring for signs and symptoms of bleeding in the gums. Watch for guaiacking of all stools. Make sure their kidney function is appropriate and adequate. And I hate to say it, nosebleeds, they're kind of critical too. It requires a lot of pressure and a lot of interventions to stop a nosebleed when a person is on blood thinners. Thrombocytopenia occurs when the platelet count is below 100,000. It takes 5 days for necessarily to resolve if it's related to heparin. DC heparin, give an antidote. You want to make sure that you are preventing bleeding, internal bleeding. Platelets must be monitored. Make sure you are gathering a good health history. Make sure you're looking for drugs, herbs that interact. Salicylates, neomycin antibiotic, quinidine, which is an antiarrhythmic, green tea, and ginseng. Are they being used? Make sure the doctors are aware of that before they make this prescription. Make sure you are teaching their patient to have a consistent diet of vitamin K intake while on Coumadin. Don't accelerate the amount of green leafy vegetables at this point, but make sure that they are consistent, that their diet doesn't change dramatically, because that's what their therapeutic level is based on. Exercise, early ambulation is sufficient for exercise after surgery or an illness. The quicker they're up and moving about, they're using those larger muscles to help the venous structure support blood flow. Get them up and move them. You want to make sure you are always telling your patient to monitor for signs and symptoms of bleeding, that GI bleed, the bleeding of the gums, that nosebleed. And of course, alert family members for the potential of pulmonary emboli. A patient who is experiencing a pulmonary emboli may not realize that they are confused. best person who could know that is the family member. For that pulmonary emboli, monitor for it is an obstruction of the pulmonary artery of one of the branches by a thrombus. It causes dead space in the alveoli. It increases impaired gas exchange. Signs and symptoms of shortness of breath, tachypnea, sudden chest pain, anxiety, tachycardia, syncope. Make sure you know what syncope is. That'll be used consistently. It's that feeling where you are lightheaded and pass out, or is that feeling when you get to that lightheaded place before pass out. Sudden onset of symptoms. Treatment includes a quick assessment to determine if it's a PE and oxygen and anticoagulation therapy. So summary. Early ambulation after surgery could do a lot to prevent the formation of thrombus. Using the lower extremities, using those leg muscles is necessarily essential for promoting circulation. If elastic stockings are necessary, please make sure if you're using thigh high or knee high, you are making sure that there is no binding of those stockings in any one particular area. If you're using thigh high, please make sure that gusset, that spot in the elastic stocking that you could see in the extension of that left leg, make sure that's over the femoral artery as to not promote a tourniquet-like effect on that artery. If there are sequential compression devices, please make sure you are monitoring and make sure you have a pump with them because it requires a pump. And they stimulate the idea that you are walking. Trick the body. And make sure the patient is always adequately hydrated. That kind of concludes our lecture. Thank you very much. Please, guys, stay safe and have a great day.